thank you very much. It's an honor to be virtually with all of you. I've never been to Iraq, but glad to see you in the months or years to come. So in the next minutes, we are going to talk about the relationship between the heart and the lungs in COPD patients. So okay, so this is the agenda for the next 20 minutes. We will start talking about COPD as a model of chronic disease in the 21st century. As the previous colleagues have said before, COPD is associated with a huge mortality and disability burden. For example, if we take the data from the global burden of disease, here you can see the deaths. The deaths in different parts of the world within respiratory diseases. The green bars are COPD, the red bars are asthma, and the blue ones are interstitial lung diseases. So for both males and females, you can see that if you have to die due to a respiratory disease, probably it will be COPD. So COPD is the leading cause of death among respiratory diseases. It's also associated with a huge disability burden. Here you can see also for all the regions in the world, the same message. COPD is the first cause of years lived with disability all around the world. And it's also recognized not only as just a pulmonary disease, but also a disease that is usually accompanied by comorbid disease, what we call comorbidities. So if you look at this data from Miguel Divo and the Bode group, you can see that these are different comorbidities that are usually associated with COPD. Some of them relate to cardiovascular disease. Some of them relates to endocrinology diseases or the area of metabolism. Some of them are related to other pulmonary diseases that come together with COPD, as previously said, and also some of them that are related to mental health. Those who are within this circle are the ones that are clearly associated with an increased risk of mortality in COPD, and the size of the circle represents the prevalence of this disease in COPD population. So as you can see, the closest to the center of the circle is the increased risk for death. So as you can see, there are many cardiovascular diseases that are associated with an increased risk, an increased mortality risk in COPD, mainly chronic heart failure, coronary arterial disease, and atrial fibrillation. And cardiovascular disease, indeed, is a frequent cause of death among people or patients with COPD. Here you have 5 landmark, let's say, studies in COPD. Most of them are randomized clinical trials. And you can see the proportion of deaths during these studies that were due to cardiovascular causes. For example, you can have about or almost a 40% cardiovascular deaths in the Euroscope trial, and about 50% in the uplift trial. Of course, this depends on whether these randomized control trials included more severe or less severe COPD patients. Because also the causes of mortality differs between different severities of COPD. If you take only moderate or mild COPD, you will see that these type of patients will probably die because of cardiac disease or lung cancer. And if you take into account only those with severe or very severe COPD, you will see that the respiratory cause of death is probably the most frequent among this population. So cardiovascular disease is very frequent in COPD. It's associated with increased mortality, but one should wonder always that they share common risk factors. So, for example, tobacco smoking is associated with cardiovascular disease and COPD. But COPD itself, it's a cardiovascular, or should be considered as a cardiovascular risk factor. For example, here you have a study at the population level in England where the authors aim to seek the incidence of first acute coronary syndrome or the first cerebrovascular accident. And you can see that the COPD population had an increased risk of incident cardiovascular disease, either coronary syndromes or either cardiovascular cerebrovascular disease. But this was even if corrected or adjusted for cardiovascular risk factors. So it seems that COPD by itself increased the risk of cardiovascular diseases. So let's talk about cardiopulmonary risk in COPD. This is a recent publication that for the first time includes a definition of what is cardiopulmonary risk. Cardiopulmonary risk is the risk of serious respiratory and/or cardiovascular events in patients with COPD. So you have COPD, you have symptoms due to COPD that increase the risk, as previously said by my colleagues, of COPD exacerbations. COPD exacerbations by themselves increase the risk of cardiovascular events. And obviously, if you have a cardiovascular event, sometimes it would lead you to COPD exacerbations. And at the end, you will have an early death due to COPD exacerbations, but also due to these cardiovascular events. So keep in mind this diamond, this figure, because it will be shown in the next months very frequently to understand this. So which are the potential mechanisms of this cardiopulmonary risk? So, of course, exacerbations amplify the drivers because, as the colleagues have said before, they increase the risk of cardiovascular events, but also of pulmonary bad outcomes. And the mechanisms underlying this cardiopulmonary risk should be inflammation. You know that COPD has some figures of systemic inflammation by CRP and so on that could promote endothelial damage. Also, the hyperinflation that you can see also in COPD patients is associated with compression of the heart chambers. So it's been demonstrated that hyperinflation is associated with worse cardiac output. And Of course, hypoxemia, which is present in many patients with COPD, leads to a higher pulmonary arterial pressure and, at the end, the right atrial failure. And we have also drugs that could target this cardiopulmonary risk and decrease the risk for cardiopulmonary events in COPD. For example, ICS is well known to reduce the inflammation in the lung. The dual bronchodilation, LABA-LAMA, decreases hyperinflation and can provide an increase in cardiac output. And of course, ICS and bronchodilators can improve ventilation perfusion mismatching in COPD, resulting in less hypoxemia. So, as I said, exacerbations are right now recognized as the main drivers of cardiopulmonary risk. Let's talk a little about this. So, a key message right now in the COPD field is that no one exacerbation is good for your patients. This is a study performed in a UK population and of patients with COPD, and is looking at 10-year mortality rates among those patients with COPD, and they were split in different groups depending on the presence or not of moderate or severe COPD exacerbation in the previous year. So as you can see, the best line where you could be should be this one, which is no exacerbations in the previous year. We know that. If a patient has no exacerbation, that is very good news for him. The worst scenario should be an hospitalization, a severe COPD exacerbation, where at 10 years, you will probably find only a 40% survival. And then you have moderate exacerbations, which are not always recognized by clinicians as a key target for prevention. And you can see that the cumulative number of moderate exacerbations increase also the risk of mortality, of long-term mortality. So you have 1, 2, 3, 4, or 5 or more moderate exacerbations in the previous year, and you can see the risk of death is increasing among the number of COPD moderate exacerbations. As I said before, severe exacerbations, those who require hospitalization are critical in the evaluation of COPD because they have a very important impact in either short and long-term mortality. For example, you have this data coming from South Korea, when you can see that at 90 days after discharge, the mortality is around 8% in patients hospitalized due to a severe COPD exacerbation. I should recall you that mortality rates for acute coronary syndromes are lower than this 8% at 90 days. But also in the long term, and this is for the work of Sami Suisa and colleagues, you can see also that by almost 4 years after the first severe exacerbation, half of the patients will die due to different causes, but mainly due to respiratory diseases. And what we know right now is that the incidence of cardiovascular disease after COPD exacerbation is also high and associated with the severity of the disease. You can see, for example, this publication of, this is a post-hoc analysis of the SUMMIT trial, when you can see the risk of cardiovascular diseases among those participants in this randomized clinical trial. And the risk, if you take all the exacerbations, moderate and severe ones, you can see that there is a clear risk of having a cardiovascular disease, which is greater in the first month, but lasts for a year. And of course, if this exacerbation requires hospitalization, this risk is higher and lasts for a year. So even moderate exacerbations, but of course, severe exacerbations had an impact in the cardiovascular outcomes in COPD. These results have been replicated in different cohorts. For example, you have this one from, this is just for myocardial infarction, not just all the cardiovascular diseases, but it's more or less the same message. If you have a severe COPD exacerbation, there is a clear risk in the first month of having a myocardial infarction, and this risk is increased for almost a year too. So what is now the recommended COPD management? I will not go deep into gold recommendations as the colleagues have talked before, but just to underline what we are doing right now and what are we facing in the next years. So which are the treatment recommendations in COPD? So if you recommend or prescribe a treatment, either pharmacological or non-pharmacological treatment for a patient with COPD, you will try to decrease symptoms. That means decrease the use of rescue medication, decrease the cough, the sputum production, and of course, improve exercise tolerance and decrease the dyspnea. These are the targets of bronchodilators in COPD. That's what we are looking when we prescribe bronchodilators. But also these are short-term outcomes. We want also long-term objectives when we are prescribing therapies for COPD. And that's called decreased risk. Decreased risk means long-term outcomes. We want patients not to get admitted to the hospital. We want also to preserve the lung function and of course avoid premature mortality. These are the objectives that are usually determined or efficacy by the ICS component of the drugs that we prescribe in COPD. And of course, if you have a patient with a risk of exacerbation, you should reduce the risk of these cardiopulmonary events and premature mortality. You should identify at-risk patients, which are the ones. These are symptomatic patients, and of course, patients with a recent history of exacerbations. Then you should optimize management, and this includes either non-pharmacological or pharmacological treatments. And therefore, you should improve outcomes by smoking cessation, pulmonary rehabilitation, and also with pharmacological therapy. And of course, if you want to reduce the risk of future events in COPD patients, you should fight against therapeutic inertia, which contributes to poor management of COPD. As I said before, pharmacological therapy is not just only the approach for patients with COPD, but you need also more of non-pharmacological interventions. For example, smoking cessation, assess pulmonary rehabilitation, referral, increased physical activity, Of course, there are interventions in self-management that could provide better outcomes for patients. The flu shot and the pneumococcal vaccination, as I said in the previous talk, are also warranted for patients with COPD, and also if the patient needs oxygen therapy or
you have only 5 minutes left.
Okay, thank you very much. I will do it. And oxygen therapy if the patient needs due to respiratory failure. The Canadian COPD guidelines, which were presented and published early this year, have divided or recommended to divide patients in mild, or moderate, and severe, and divide them and split them in low symptom burden, so receiving LABA or LAMA, low COPD exacerbation risk, so you will go through LABA-LAMA, and of course a group of high exacerbation risk where triple therapy should be the main pharmacological therapy for these patients. But let's go further into the next future. Is another approach to COPD management possible? So if you think of cardiovascular disease prevention, cardiovascular disease have a clear pathology. It has also a clear recognized cardiovascular risk factors. So the cardiologists have used cardiovascular risk scales to detect which are the patients who have increased risk for bad outcomes, and then is it possible to prevent cardiovascular disease by primary prevention. What we are facing right now in COPD is it possible to prevent primary COPD exacerbation? So we have COPD exacerbations. We know the pathology that is associated with these events. We know the exacerbation risk factors in COPD, but we don't have right now risk scales for the development of exacerbations, and so on. We cannot primary prevent. But if we had this type of scales, which are right now, many groups are around the world working on that, probably we will get a primary prevention for COPD exacerbations. And finally, what is the role of triple therapy in COPD? So triple therapy increases lung function, improves lung function against other pharmacological therapies like LABA-LAMA or LABA-ICS. You can see the results of the Kronos primary outcome here. COPD is also well known as a therapeutical intervention that provides a decrease in the rates and the risk of COPD exacerbations. And this is probably performed due to the eosinophil blood count. Whenever you get more eosinophils in your blood, the prevention or the risk of exacerbations decrease with triple therapy against LABA-LAMA. But the most important data from the triple therapy right now in COPD is the fact that triple therapy can provide a reduction in mortality. This is the ethos pre-specified outcome, when you can see that triple therapy is associated with a decreased mortality risk compared to LABA-LAMA. And then you will have only to treat 80 patients in a year with triple therapy to reduce or to prevent one death in COPD compared to LABA-LAMA. And please keep in mind these 80 number needed to treat. And this is probably one of the most intriguing results from the ethos and from the other trials in COPD, in triple therapy in COPD, is that the reduction in mortality is more pronounced due to cardiovascular disease. So you have here the rates 0.5 compared to 1.4 with lava-lama. So triple therapy seems to reduce all-cause mortality, but mainly due to a reduction in cardiovascular mortality. In fact, if you put the number needed to treat in context, you will see here many of the cardiovascular landmark studies that made a change in guidelines in the recent years. You have the Scandinavian simvastatin survival study, the heart protection study, the HOPE study, and the empagliflozin REG study. Also on the right side, you can see results of the number needed to treat to prevent one death with the COVID vaccines. And these are the number needed to treat for mortality to prevent one mortality or one death in cardiovascular diseases. Here you can see the number needed to treat to prevent one death in COVID vaccine trials. And here you can see the results of the ETHOS trial. So to put in context, the number needed to treat is lower than many of the landmark cardiovascular studies, which provided a change in the clinical guidelines. And with that, I will just like to finish and summarize the take-home message. COPD is the most frequent respiratory disease around the world and is still a very frequent cause of death worldwide. There have been significant changes in clinical practice guidelines in the latest decades with a more preventive approach for COPD exacerbations. Just for example, the Canadian guidelines I have shown you before. Triple therapy offers improvement in lung function, health-related quality of life, exacerbation prevention, and mortality compared to other pharmacological approaches. And adherent and prone initiation of single inhaler triple therapy are key components of triple therapy in COPD management. And with that, I would like to thank you for your attention and also invite you to come to Granada, my city where I live, and where you can see this famous part of the Alhambra, the Muslim castle in Granada, which is called the Partal. Thank you very much for your attention and happy to answer your questions right now.